On the behalf of NKDB, which is the Norwegian National Resource System for people with deafblindness, I want to welcome all the participants to this webinar. We are gathered participants from all over the world. My name is Rolf Lund, and I will be your host for this webinar. You just have to lean back and follow the presentations. If you have comments or questions, please use the chat function to the left in the window. Just click on the little white arrow and you can choose between seeing the names of the participants or use the chat by clicking on the talking bubble and type your questions on the lower window. We will respond directly or by asking the presenter at the end of the session. Today, the demand at professionals to work on a science-based knowledge has increased. We are expected to be up to date with new research in our professional field. NKDB has established a research network between professionals working in the field of deafblindness in Norway. One of the tasks this network is given is to promote and support research in our field. One way of doing this is to arrange a meeting point. Originally, this was meant to be a physical conference where we could meet, learn to know each other, and learn from each other. But under the corona, this became impossible. We therefore decided to do it anyhow, but as webinars. Our research network has decided to focus especially on research methods in these webinars. This is because research in deafblindness has its specific challenges. Today, it's time for the 3 last lectures in our webinar series on research on deafblindness. Hopefully, this webinar series has encouraged the production and sharing of new knowledge. Speakers today will be Mattias Ehn from Sweden, Arnstein Gregersen, and Rosemarie van den Bremer, both from Norway. Each lecture will last approximately 35 minutes, with an additional 10 minutes for questions, followed by a 15-minute break between the lectures. Our first speaker is Mattias Ehn. He is a PhD and psychologist at the Stockholm Region Counseling and Support Team for people with deafblindness. He is active in deafblind research at the Audiological Research Center at Örebro University in Sweden. His presentation is called Quantitative and Qualitative Methods when Studying Health in People with Usher Syndrome. So, Mattias, please start.
Thank you, Rolf, for this excellent presentation. I wonder if I can see the first slide of my presentation. It's not visible for me at the moment, but I don't know if that's just my... here it is. Yeah, thank you. As Rolf said, I am a clinical psychologist, and at the moment I'm in Stockholm, actually in my home. After the COVID-19, it seems like we spend more time at home. Right. At the moment I work full-time as a clinical psychologist, but a year from now I had the opportunity to present a thesis in which I have been studying health in people with Usher syndrome. This thesis had especially 2 things that I looked upon, and that was life strategies in people with Usher syndrome, and that was work life and the impact of working life on health in people with Usher syndrome. My research group in Örebro is, we have some other persons there. Moa Wahlqvist used to be my supervisor, and she has also been studying health in this group. And Claes Möller, who is Professor Emeritus now, and he has been collecting data for a very long time. So a lot of our studies are upon Usher syndrome. Okay, so we can go to the next slide, please. I just want shortly to brief you. I don't know if everyone is acquainted with Usher syndrome. It's a recessive inherited disorder that is actually the most common cause of deaf blindness in adults if you don't regard elderly people who mostly have non-syndromic causes of deaf blindness. But Usher syndrome is recessively inherited, and normally when you have a child with Usher syndrome, the parents do not have Usher syndrome. You are we have a classification with 3 different types that is based on clinical observation, and that is type 1, where you are born with a profound deafness that is congenital, and you have the eye disease retinitis pigmentosa that gradually limits the vision, especially the vision field, and also the night vision, causing severe problems, and in the adolescence and young adulthood really restricts the visual abilities. It can also affect the visual acuity later on in the onset, in the process. The other clinical type that I will talk most about today is Usher syndrome type 2. Then you have a moderate to severe hearing loss from early childhood, and normally the retinitis pigmentosa, which is also occurring in this, it has as a small child you are not very affected visually, so the age of diagnosis is quite often late in these children. At least it used to be before genetic analysis became more occurrent. The 2 first types of Usher, they are equally common, and then there is a third type called Usher type 3, which is quite common in Finland, but also in other Nordic countries. And then you have a progression in hearing problems, in vision problems, and also balance problems, which I forgot to mention on the first clinical type. 1 child per 1,000 about has Usher syndrome. Okay. We have been collecting a lot of data in Örebro for the last 30 years, as I said, on hearing and vision. So we know quite much about the vision and hearing in people with Usher syndrome. A lot of genetic research has been going on, not in Örebro so much, but on other places in the world. So now we know that the clinical types are more, actually there are many genes that causes Usher syndrome, many different genes. There are many, sometimes you say 13 genes, sometimes you say like 19 genes, and it depends what report you write. But we learn a lot more about the vision and hearing problems. But what I have been studying, and now we can go to the next slide, please. That is, do people with Usher syndrome have other health problems? Except from the vision and hearing problems, and what kind of health problems could that be, and how are they related to the limitations in vision and hearing? The project in trying to do research about this started up in 2007, and it was my colleague Moa Wahlqvist who started, and we at that time I was not active, but the research group started up, and we thought about what is the best way to learn more about the health problems. And then we went to the Public Health Agency of Sweden. We asked for a questionnaire that they normally send out to the population or a random sample of the Swedish population every second year. And we tried to adjust it as much as possible. So we asked for permission to use that and send a special edition to people with Usher syndrome that we had in our register. And that was a questionnaire. So there are a lot of questions, items to be filled in. And I will, actually, this led to not just one study concerning people with Usher syndrome and their health in relation to the general population, which was the first aim, but also when second analysis was made, was the start-up of my PhD project, which covered working life and health in people with Usher syndrome. This picture perhaps illustrates how easy it can be filling out forms when you have Usher syndrome. You have a very limited vision or no vision at all, and you are asked to fill in a form with like 80 or 90 questions, sometimes with an A, B, C, D, and E. Though it was quite difficult, we had we sent out questionnaires to 122 persons, and we had a response rate of 96, which is almost 80%. That is far, far higher than the Swedish Public Health Agency get response. So we could see that the people with Usher syndrome were very committed in responding when we wanted to learn more about their health. We could also do different kind of analysis of this material. The statistical analysis of small groups is often a very tricky one, because you need large sample sizes when there are a lot of people in each group, and you make a cross-sectional study, as we did. We compared the people with Usher syndrome to the people who of the general population. We could compare the results. And if you want to find out and to find statistical analysis, you use non-parametric chi-square testing that we did. And what you can find when you have small sample sizes is, if you get statistical significance, it is quite big differences between the group. If you have bigger sample sizes, small differences can also be statistically significant. And we can go on to the next slide. Here are some results when we compared the bars that you see. We have blue bars and red bars, and the red bars represent the general population. And what we have different kind of indicators, and I know that it's difficult to see, different kind of indicators indicating poor health. So the higher the bars are, the more reported poor health people have. So we have headache, we have tinnitus, we have stress, we have sleeping problems, we have fatigue, depression, anxiety, suicidal thoughts, and suicidal attempts, just to mention a few. Feeling worthless, difficult to concentrate. In many, many aspects, we could find out that people with Usher syndrome, they had a much worse they had more problems than did the general population. And this was perhaps also what we might have expected. I want you to especially look at the highest bar, which almost is up on 80%, and that is one indicator called fatigue. And why I say that is I will come back to it later on in my presentation, and we can go to the next slide. When I made an analysis of the the material, what we could see was that the people with Usher syndrome, they had a lot of health problems, but it seemed like some people, they had more health problems than others. And so within the group of people with Usher syndrome, I made an analysis with different kind of crosstabs, where suddenly I saw that one variable, working life, that we've been asking for, are people work active or not? It seemed to divide the results in two. After doing more statistical analysis, I could see that when looking at the graphs, the bars of poor health, people who were not work active, they seemed to be the one who presented the poor health. And this slide, we have the blue bars that are people with Usher syndrome type 2 who are work active, and the red bars are the ones who have a full disability pension. So they are not work active at all, but they have some kind of remuneration from the Swedish state and the welfare system. We can see that they have been employed, but at some point they have left the labor market. And they are the ones who in a much higher degree are depressed, have anxiety, are worrying, and present suicidal thoughts and so on. And we can go to the next slide. When it comes to the physical indicators, we could not see the same difference. Actually, the bars are higher, so the occurrence of problems are in people reporting them much higher than the psychological problems. But if you go to the one fatigue that I've been talking about, and I will come back and explain what fatigue is later on, you can see that if you compare people who are work active to the ones who were on full disability pension, both of them are very high. Okay, so please go to the next slide, please. So what can we conclude? With this kind of method, the quantitative method that we used, comparing, we can compare data from, at least in a deaf-blind context, we can really go wide. We have a lot of people, 96 people answering a questionnaire in a deaf-blind setting is a lot of people. That is, I don't know if there are many research studies in deaf-blindness that has covered more people than that in any setting, actually. It's more common with single case studies and small sample sizes. So we can really find statistically significant differences. That is the most important thing with this method. But we could also find out that we have a really significant difference from the Swedish population, which is important. From anecdotes, we know that, but now we have really research on that. We have findings that we can statistically see that this is the case. We could also see that there are psychological difference. If you're work active, you seem to have a lot of benefits from that psychologically. But some of these correlations that we found, it is really correlations. We don't still know anything about, is it so that people who are psychologically unfit or do not feel well, they leave work life because of that? Or is it so that working life keep people healthier? We do not know anything about the causality after just one measurement like we did in this cross-sectional study. So that is really a limitation. So what we concluded was that we needed further studies. Please go to the next slide. And one of the variables that I talked about earlier was fatigue. And fatigue is, you could really have put that bar both on the psychological health problem and the physical health problem, because it's really a state of tiredness that is bodily and mentally. And it's not a sleepiness, it's really something that you cannot rest from after a few days sleep or just relaxing for a while. What you could see is that in research about people with hearing loss, acquired hearing loss, especially in working life, it's very common that people have fatigue. And there has been a lot of more research in that population. Quite recently, a Norwegian study of Svindal presented very interesting results about people with hearing loss, but they do not include people with deaf blindness. We can go to the next slide, please. So, how can we learn more about the situation of working life? After having this quantitative study, a lot of hypotheses emerged, a lot of new research questions about the situation of the, on the one side, good psychological health of people with Usher syndrome in working life, and on the other side, the fatigue. How can we understand that? So we thought that instead of sending out another questionnaire, people's narratives telling us about their situation would be appropriate to learn more and get deeper into this question. We can go to the next slide, please. So what we conducted was an explorative, qualitative study. And since it's quite difficult to get in contact with people with Usher syndrome in the working life, we also knew that in order to be able to do a study, we could not include like 20, 30 people. Instead, we choose to use another way of analyzing our data, which is called interpretative phenomenological analysis. So what we want to know is, want to learn more about people's lived experiences, what they have learned from what they think about their situation and how they feel about it. But the interpretative addition to that is that you as a researcher, or in this case me, Claes Möller, Moa Wahlqvist and Agneta Andersen Karlsson, who are all we all from our clinical work knew about this group quite a lot. We can also, in a late step in the analysis, include this knowledge in the analysis. And that is the particular of this method. So we included 8 participants. We asked 10 and 8 responded, and they said that we could include them. One important thing to use this method is that you have quite a homogeneous group. So we narrowed the age range from 35 to 50 years in order to find people with Usher syndrome who are in working life. They are working 50% or more, which means at least 20 hours a week, so that they are really work active. And we also wanted them to have been work active for the last year. And we also had the age range, not really, first of all, for them to have a lot of work experience, but mostly because we know that people in the 35 to 50 years, they have really developed much problems in their vision, which is perhaps not the case if you're 20 years old. Okay, we can go to the next slide. What we did, actually, I made individual interviews, and I had a semi-structured interview guide doing these interviews. And I audio recorded them, and they were transcribed and then analyzed in a special set where you go from the really manifest content to a more interpretative process. We found out that there were 4 themes that occurred from these interviews when people talked about their working life and the working life in relation to their health. First of all, working life really could give them a lot of satisfaction. You had the opportunity to have use of your knowledge. People were working in with many different things and in different areas. But what we could see that people were really skilled in what they were doing. Working life was also really a good arena for meeting other people. You had a lot of the persons who were there. They really told us that this was the place where you have most of your social interaction. So that was 2 important things, and that could perhaps explain some of the psychological better health of people with Usher syndrome who are work active. But we could also identify that this was an act of balance. People were so committed. They were working a lot. They made special adjustments to be able to work a lot. Some people had to take away a few of the work tasks because it wasn't possible anymore. Some spend extra effort doing what they needed to do at work, and this had a price, especially on family life and leisure time. People were exhausted. They were tired when they got home from work each day, and the weekends sometimes was not more than trying to get enough rest for the upcoming week. Still, the work was important, and this was a choice they have made to sort of prioritize working life. And I have a picture of balance here, I'd say. And this was really the most important thing to see, that in working life, perhaps more than somewhere else, if you have deafblindness, you have to confront your deafblindness. You have to face your limitations. You cannot avoid them. And the extreme tiredness, the exhaustion, and sometimes finding out that, okay, this is as far as I can get in this situation, and to face one's limitations. That was also very important aspects of this. And this, I think, would not have been possible to catch with a quantitative approach or design. So this was really the depth we found in the narratives. And since the people with Usher syndrome, they have a progressive course of especially the retinal deterioration and the future, it was very, very difficult to foresee. So the uncertainty about the future was also very present. Okay, we can go to the next slide, please. So to conclude, what we found out was that after performing the second study with the narratives, with the interviews, I can go back to my first study, and I can look at the first study and understand the bars, the statistics. I can sort of make another analysis when having the qualitative study with me. And this you can call triangulation, but I think actually adding 2 two methods. First of all, I would probably not have got so much sort of pinpointing interesting issues in the qualitative study if I did not do the first study of the quantitative study. I would perhaps not even have noticed that working life was of such importance for this group, but in particular. So they sort of, both in validity or trustworthiness, I'd say, they add pieces to each other. So both of the reports are more valid together. And I think that is also an important aspect, and we can go to the next slide, please. That when you have to, if you want to study health in people, it's important not just only to acknowledge the medical condition, which used to be what we did, just looking at their hearing and vision. And one definition of health, which is from Bircher and Kurvilla, they have a very holistic definition of health. And this kind of theories, I think, is important to have in your backpack when conducting this kind of studies, that it's important to have many pieces of the health puzzle when studying people with deafblindness. We have to know a lot about the biologically given potentials of these people, about their hearing and vision. And if you know much about that, then we know just one piece of the puzzle. If we go on studying the personally acquired potentials of these people, sort of life strategies, how they handle working life and what kind of adjustments they have learned, new skills, strategies, coping strategies, for instance. But you also have to know about the demands of life, the working life. How is it? I mean, how accessible is it for people with deafblindness? What kind of things can you do if you have deafblindness? And what are the demands of working life? And that is an interesting piece of health also, that health occurs when the demands from the environment and the person, him or herself, is sort of in equilibrium with what you can perform. And one piece that we have not really put much focus on yet, but it's important for future studies, that is what we can call social determinants. What can a society offer these people in terms of accessibility aids, subsidies, but early on, correct education? In what way does legislation and also norms in our society include people with deafblindness and Usher syndrome in this case in working life? Are you someone that people in working life count on, or is it that you are rewarded a disability pension for the rest of your life? And we learn more about the possible health risk of leaving working life. So please go to the next picture. And if we have this piece of the puzzle and all the kind of the pieces, when they are sized so that they can fit together, people probably experience health. And by studying health in this manner that I did with both quantitative and qualitative methods, I think we got at least a few more of the pieces we learned a little more about. Still, there is much more to do. I think I will almost stop there. The next page, which it includes, you can go to that one. That includes 3 of the studies that I based this presentation on. That is work from the Audiological Research Center in Örebro, from Moa Wahlqvist and from me. My PhD thesis is also available if you want to read it at DIVA portal. You can download it. It's not here, but if you Google my name, you will find it. So I think I'll stop there. Thank you.
Thank you. Thank you so much, Mattias, for very good presentation. Exactly what I hoped for. It was a very good demonstration about how different methods in research can visualize or put the focus in different ways. Like you open with the quantitative method, how to get an overview and how to detect what kind of phenomenon you should study in a deeper detail. And then you use the qualitative method to get a deeper understanding through narratives. And to answer one of the big questions, like the causality between, we like to say, the hen and the egg, who was the first? Was it working life or was it health? And it's a perfect example on how when we put on different method as glasses, we see different things. And by using several methods, we can see the same thing from different angles. So thank you so much. It's still possible to ask Mattias questions since you participating in this presentations, you don't really have a mic, but you have a chat function. So if you had used the chat function on the left, you could write questions to Mattias and we would certainly answer it. In the meantime, it's normally we have this experience with these webinars that people don't really ask so many questions. So it doesn't have so much with your presentation, Mattias, to do as it might be a challenge in this kind of format to encourage people to type in questions. But is there anything you would like to add yourself from what I just comment?
No, I just want to encourage people to. I think that it's as I started up. It's very difficult to have big sample sizes when studying people with deafblindness, and one way to elicit more data is, of course, to make more international studies. If you collect data from more than one country, you can normally, if you put them together, you get a bigger sample size. So that is what I hope for the future, is to be able to not only work as we did in a national way. Studying working life could be a bit tricky because the legislation in different countries is very, very different, and the opportunities are therefore also different. But other kind of issues are perhaps more possible to use this kind of method. But still, we have this opportunity also to get the depth after making interviews, and together it's really potent. And I think I hope for the future that I will have the possibility to go on studying and learn more about the health of people who are not work active, and to perhaps see possible what I really look for the future, and what I hope for is more intervention studies. How can we find ways to now when we have these descriptive studies, because there are many descriptive studies in this group, which is not very strange because there is not much research in the area of people with deafblindness. But how can we, in a structured way, learn more about what to provide in order to, for instance, keep people have a longer, healthier working life, and for people who have left the labor market to come back again, or hopefully not leave working life in the first place, for an instance.
Yes, thank you. Yes, absolutely. Another angle is that we also, not everything necessarily have to be researched in its specialized understanding of the word. I also think that innovation studies is also very much welcomed. We would really, and that's close to what you are saying, is that we want to see the outcome of what we are doing, or also reports when we try to implement science or not new knowledge, and we try to improve our practice. We could call that innovation, and that's I think is very well suited for a lot of people listening here, that they could do innovation studies and report from that.
That is very good, I think. One thing that is important, though, is to get them widespread. It's important not only to write them in your mother tongue, but also to translate them into English, because then they, at least with the formats we have today, with the possibility to search internet and to publish things, of course, a research report has been peer-reviewed, and that is a process that sort of that is good. but still, whatever you do, try to make an English translation, because it's so much worth internationally, and I think we have to help each other out to spread the reports.
Yeah. That's absolutely. I and Ann-Britt just together with Nasrin Olsen from Sweden published an article in the DBI Review on exactly. We tried to do something in English, and I think there is a lack of presentations from our work in Scandinavia to be presented internationally, because we certainly have a lot to talk about and to tell about. So also that should also encourage people to do so. So anyhow, yes, thank you so much, Mattias.
Thank you.
This was our first session.
Yeah, thanks.
And to the audience, we will now have a break, which so you can go and get yourself a cup of coffee, stretch your legs, and we will start up again as in our agenda. We will start 1 o'clock with Arnstein Gregersen. So don't go away. Just get a cup of coffee, come back, and we will start up again exactly at 1 o'clock p.m.